Hey, good morning, everyone, and welcome to UroNurse. We meet every Saturday at 9 a.m. Central Time. If you're watching us on YouTube, great, but be sure to check out our website at uronurse.com to find out more information on how you can join us through the Zoom feed. The Zoom feed allows you to ask us questions. The YouTube feed you can watch anytime you want on demand or live right now. I have noticed that several viewers are watching us live, so great. But if you want to ask questions, you do need to join in through the Zoom feed. We've got a great show for you today. As usual, we'll start off with taking some general questions, some general things that we can talk about. If you've got comments you want to make, feel free to send those in. If you have questions, something from the last show, go ahead, send those in. After we finish with answering those questions, we'll move on to our second part of the show, which will be our presentation. And we got a great talk coming up. It's our second part to Urology 101. We're going to learn more about catheters, thanks to Andrea. So we're looking forward to some great information on that. Since I don't have any questions, I do have a few things I want to go through here. So let me switch over. Nope, wrong button. There we go. All right, great. So taking a little look ahead, just I have put a calendar up. You can look at that any time, but just to share some of the great speakers that we've lined up for you guys. Coming up October 29th, that's next weekend, we have Shivaya Kovela. She's a physical therapist. So we're going to get a physical therapy point of view. What does the pelvic floor have to do with stress urinary incontinence? So that's looking forward to a great talk from her. On November 5th, hey, got Vic Sinise again. I know that guy. We're going to finish off our discussion of erectile dysfunction with our part 3. Again, you can look at the previous series 1 and 2 on demand, but part 3, we're going to take our deep dive into the pharmacologic erections using prostaglandin E1 and other agents for injections versus intraurethral use. And we'll talk about that. Another deep dive. Then on November 12th, we have Karen Fuker coming at us. She's going to be talking about uncovering primary hyperoxaluria in practice, more than a kidney stone disease. So we've got some great speakers lined up. This one is going to be fun. We're going to see how this works, but we're going remote on November 19th. For those of you that are not familiar with the Chicago Metro chapter, they are our sponsors. They provide the cost sponsor the webinar, and their big conference is going to be November 19th, and it happens to be a Saturday. So we decided, we had a little discussion, and we're going to try to see if we can stream one of the conferences. So Dr. Kristen Baldia is going to talk about the treatment and surveillance of kidney stone disease. Now, we'll be a little different format. We'll start at our usual 9 o'clock, but I'm going to take you through the exhibit hall, hopefully, fingers crossed, and show you what's going on in the exhibit hall. And then at 9:30, her talk will go on. It'll be a 1-hour talk. You can ask any questions over our Q&A, and I'll be able to ask her those live. So we'll see how the remote works. Should be pretty easy. I did it in New Orleans. I should be able to do it in Lisle. And that's just a sneak peek at some of the things that we're going to be doing. I've got a lot of ideas, but always feel free to send in suggestions. I'm keeping a list of what you suggest so that I have that online. Just to finish off here, a little introduction. Who our panelists are today. For those of you that don't know who I am, Vic Sinise. I'm a urology nurse. I've been in practice for over 30 years. I quit county after 30. So, but that's been involved in SUNA very, strongly. I was once the president of SUNA, so I'm involved in our local chapter. Next, I have John Lynn. Give a little introduction.
Hey everyone, I'm a private practice urologist who wants to pay it forward by sharing what little experience I have in the business of medicine to benefit my colleagues. I have a strong interest in coding, billing, compliance, efficient practice management, marketing, social media, and online reputation management. I'm currently the administrator for the Thriving Urology Practice Facebook group, where about 2,000 US-based urology practice personnel collaborate to improve our practices. So feel free to join. It is free. Lastly, I run a few YouTube channels. I look forward to sharing our knowledges.
Hey, that's great. And then Andrea, why don't you introduce yourself?
My name's Andrea Strong. I'm a nurse practitioner. I've been in urology since about 2010. I've done inpatient urology, outpatient urology. I did the float pool in the outpatient setting. I'm certified as a urology nurse, and I have now about 1 year of experience as a nurse practitioner.
Hey, that's great. So as you can see, a lot of great talent that show up. Again, we invite anybody who really wants to pay it forward to join the panel. Just send me go to our website and send me a quick message that you want to join. And again, the commitment is whatever you're available. We're glad to utilize you. But I think this discussion format works out great, where we can kind of bounce things off of each other and kind of learn from each other. So I see the Q&A box seems pretty quiet today. I'd like to welcome everybody. I see April's showing up, Charlene, Claire, Diane, Emily, Gwen, Neil, Rebecca, and Susie Swain. And I was in the earlier, I'd mentioned I do get a printout at the end of the meeting of who all attended. And I was surprised because we do have one international attendee, and that's somebody from Sydney, Australia. And she was on last week's talk. So we can reach the globe now. If you have any questions, feel free to ask. This is your time to ask. But if there's no questions, we're more than glad to spend more time in our deep dive into the catheter world. Yeah, I see somebody's said something. Even if you just want to tell us good morning. Thank you, Rebecca. It is going to be a good morning. I don't know what the weather's like by everybody else, but I can tell you here in the near Chicagoland area, we're looking at possible 80-degree weather today. It's sunny out and it's beautiful. So I hope everybody's going to have a great, what do they call it, Indian summer today? Yeah. All right. Well, I'm not seeing any other questions or comments, so let's get right on with the show, and we're going to turn it over to Andrea. You can go ahead and share your screen. As she's talking, feel free to put any questions that you might have and just put those in, and we'll answer those when we get to it. Anytime you are ready, I'm going to spotlight you.
Okay. All right, so we're going to pick up on part 2 of the catheter presentation. So we're going to talk about specialty catheters at this point. All right, so just a few specialty catheters that you may have seen used in practice. The silastic catheters are green in color, and the purpose is to help reduce calcification buildup. I have seen these used a few times in the past. I'm not currently using them in my practice, so I'd be curious if anyone else is using these regularly to prevent calcium buildup. Silicone catheters, these are clear in color. These you'll want to use generally for patients with a latex allergy, but there are some times when we're using it for other purposes. These catheters tend to be a little more stiff. So occasionally you'll see us using those to try to place a catheter that may be a little bit more difficult. The balloon on these catheters will lose water a little bit faster. And then in general, it's recommended for use in patients needing long-term indwelling catheters to help prevent any allergies to latex. And then the 3-way catheters. So these are used for irrigation. So you're going to see 3 different ports there. One is to inflate the balloon. One is to instill water into the bladder, and the other one is the exit for the urine or your irrigant to go out. These are usually used after surgery, so especially after a TURBT, when we expect some bleeding, they can irrigate that out with a 3-way catheter. All right, so now we're going to talk about clean intermittent catheterization. It's also known as CIC or self-cath or intermittent self-cath. And this is a safer alternative to indwelling catheters. So I see many patients with spinal cord injuries or bladders that are no longer contracting for a variety of reasons. If the patient's able to, if they have the mobility, I always encourage clean intermittent catheterization because it's safer for the patient. There's less risk of infections. There's still some risk of stone formation for these patients. So I always tell the patients, when you're doing clean intermittent catheterization, make sure that there's no hairs or fuzz or lint that enters into the body when you're placing your catheter, because the body will form a bladder stone around that piece of hair or lint or whatever enters the bladder. Sometimes patients don't have the mobility to perform clean intermittent catheterization. So sometimes they have a care team at home or a family member that can do clean intermittent catheterization, and sometimes they don't. But overall, this is encouraged over an indwelling catheter. So it's performed at timed intervals. If the patient can't void at all, I recommend every 4 to 6 hours. I'll usually have the patient write down what their volumes are when I first start them on clean intermittent catheterization. I like to keep the patient's volumes in their bladder less than 500 or less than 300 sometimes, to help protect the integrity of their bladder and their upper tracts. Sometimes patients will just have incomplete emptying and they'll only need to catheterize once or twice a day. It can be short-term management or it can be long-term management. This is a non-sterile technique when the patients are doing this in the home, and the catheters are single use. I'm sure we've all seen the patients that come into the clinic who maybe started catheterizing in the 1980s, and at that time they were just approving 1 catheter per month, so the patients will reuse them. I even had one patient come in who had his catheter tucked into his sock, and he reused the same catheter for long periods of time, and he did fine with that. But the current recommendation is for single use on these catheters. So we already talked about ensuring no pubic hair, lint, or fuzz, anything gets on the catheter as it enters. And, I always tell patients self-catheter options are like the grocery store cereal aisle. There's tons and tons of catheters available. They all claim to be the best. I let the patients choose what they prefer. Unless the patients had a lot of infections, sometimes our spinal cord injury patients will have a lot of infections. And in that case, I will do the closed catheter system. That's a system that helps protect against urinary tract infections. I won't go into that today because I got a lot to cover. But so in general, clean intermittent catheterization, I'm going to review how to teach your patients how to do this. So you want to make sure that the patient understands they need to wash their hands before catheter insertion, preferably with soap and water. They'll also clean the meatus with usually warm soap or water, or sometimes they have some little wipes that the patients can use at the meatus as well. Excuse me. I need to grab a drink of water here. So lubricant. So some of these catheters are hydrophilic, meaning that they're self-lubricated and you don't need the separate lubricant. Some of them are non-hydrophilic. They're not, so you need to use the lubricant with those. And then if you're having the patient collect the urine for the outputs, they'll need a urinal or an appropriate collection container. So females can perform clean intermittent catheterization in any position that they're comfortable with. Same thing for males. They'll want to spread the labia, clean the meatus, and then sometimes a mirror can really help patients identify where the urethra is. If I show patients this picture, it usually helps them understand the area that they're aiming for clean intermittent catheterization. So you can see the bladder there in the front, the vagina and the uterus, and then the rectum. So for females, I always tell them that their urethra is located just below the clitoris and just above the vagina. It's usually seen as a small V, although you may see variations, especially in patients who are postmenopausal. They can have some vaginal atrophy. Sometimes the females can have a carbuncle, which will be sort of a reddened area where the meatus is there. You may see that. You may even see a prolapsed meatus in a female. And they'll want to lubricate the tip of the catheter, slowly and gently insert the catheter about 2 to 4 inches until urine starts to flow. I always tell patients, once the urine comes out, you know you're in the right spot. You can insert a couple inches more, but then you know you're in the right spot when you get urine. Allow the urine to empty to in the collection container or into the toilet. And then when the urine stops, slowly withdraw the catheter. They may hit some more pockets of urine as the patient's pulling the catheter out. I tell them just stop there, allow the urine to drain. So clean intermittent catheterization for males. Again, you'll want to teach them how to wash their hands thoroughly, find a comfortable position. They want to hold the penis perpendicular to the body, sort of pointing up towards the belly button, wash their meatus, and then for uncircumcised men, retract the foreskin and clean the meatus, the same method. I show all my male patients a photo here of the male system so that they're understanding the curvature of the male urethra and what it looks like to kind of navigate around that prostatic urethra. So again, we'll need to lubricate the tip of the catheter if the patient's not using a hydrophilic. Slowly and gently insert the catheter into the meatus, usually 6 to 8 inches, or really until the patient starts to get urine coming out of the other end. If they meet resistance to the passage of the catheter at the prostatic urethra, I tell patients to hold firm, gentle, steady pressure, but not to push really hard, because patients can actually develop false passages when doing clean intermittent catheterization. Again, keep the catheter in place until the flow of urine stops, and then slowly and gently withdraw the catheter, allowing for any pockets of urine to drain. All right, so supra-pubic catheters. I think most of our participants are familiar with these, but in case you're not, I'm just going to review. Supra-pubic catheters is basically the same exact system that you would use for a urethral catheter, but it's placed through the lower abdomen directly into the bladder. If a patient needs long-term catheter, we will usually encourage the patients to have a supra-pubic catheter placed because it helps prevent from breakdown of skin at the meatus for males and females. Especially in female patients, if they have catheters indwelling catheters for a long time, it can cause urethral erosion. So the urethra will slowly be stretched and eroded over time. And if that gets severe enough that the urethra will just remain open and the patient will be entirely incontinent of urine and have to wear some sort of continence device for the rest of their life. There is a surgery to correct that, although it's not a very successful surgery. So we like to prevent that if possible. This is usually done as a surgical outpatient procedure. The patient's put under anesthesia, usually a MAC anesthesia. They'll fill the bladder with water, do an ultrasound just to make sure that there's no bowels in front of that bladder. And then they just, insert a small trocar to place a small opening into the lower abdomen. And then we place the suprapubic catheter. I always tell patients that this still has a risk of infection, still has a risk of stones forming in the bladder, but there's less risk of urethral erosion. So removal and insertion of a suprapubic catheter that's brand new is generally done by a physician or an advanced practice provider. The track is not yet established during the patient's first change of that suprapubic tube. So you want to be real cautious. I do change these patients' suprapubic catheters for the first time in clinic. I always make sure that the patient is completely supine when doing this, and that helps prevent any misplacement of the catheter in the wrong area. You don't want to change it until 4 to 6 weeks after insertion, and make sure that the patients understand that once that tube is placed, it still needs to be changed every 4 to 6 weeks, the same as a urethral catheter. So insertion tips for suprapubic catheters. You want to inflate the bladder with sterile saline or sterile water before changing the tube. That helps you know if you're in the correct position. So I will usually instill 2 Tumis worth of sterile water or sterile saline, so about 120 milliliters, clamp their existing catheter. And then I will always do a quick change. I'll usually have someone else in the room who will remove the previous catheter, and then I will immediately clean and replace a new catheter, especially if it's a new track, because those tracks can close up quickly. If the patient's had a suprapubic catheter for a long time, then they're usually fine having the suprapubic out for a few minutes for the change. Do not inflate the balloon if there's resistance or if the patient complains of a lot of pain while you're inserting or while you're inflating the balloon. It's always possible that you're trying to inflate the balloon in an area that's not in the bladder. You could be in the urethra. In males, you could be in the prostate. You could also be not far enough, so sort of inflating it within the track of the suprapubic catheter. Don't fully insert to the Y connection. I know in the past it's been suggested when you're inserting a urethral catheter for a male, you should insert all the way down to the Y hub, but don't do that for suprapubic catheters because you could inflate the balloon in the patient's urethra or prostatic urethra and cause permanent damage. All right, so external urinary catheters. So first I'm going to cover male external urinary catheters, also known as Texas catheters, also known as condom catheters. One important thing I wanted to point out is that there's actually a measuring device for these. There's different sizes. It should come with a little piece of paper you can see at the bottom of the screen here, and it's going to tell you what size to use for the patient. I see that this step is commonly missed in the clinical setting. So make sure that you're measuring for the correct size for male external catheters. So in the inpatient setting, you want to change it at least every 24 hours. In the outpatient setting, I tell my patients they can wear it for 8 hours, but I don't like to have them wear it for any longer than that. Complications may include penile skin maceration, ulceration, necrosis, allergic reactions, irritation. You may see benzoin sometimes used in the inpatient setting to help dressings stay in place. Don't use benzoin for these external male catheters because it can cause skin damage. So teaching patients how to use these at home, they'll need to wash the penis with soap and water and dry before placement. You want to assess for skin breakdown every shift if you're in the inpatient setting. In the outpatient setting, I tell patients to just really inspect all of their tissue on a daily basis to make sure that there's no skin breakdown happening. For uncircumcised males, they should not retract the foreskin before placing this. Use soap and water, like warm soap and water and a washcloth to help with removal of the external urinary catheter. Sometimes it's a little bit uncomfortable for patients to remove it, especially if there's a lot of hair present, because it can kind of pull. All right, so the PureWick catheters. So I don't have a lot of personal experience with these. When I stopped working on the inpatient floor in 2013, they had just started using PureWick catheters, but only in the ICUs and only in certain scenarios. But I do have patients asking about these in the outpatient setting. So I looked up a few things. So the cost of this is $594 for the starter kit. So the starter kit is going to include your cylinder, and it also includes a box of, I think, 30 of the external catheters. If you get the system without the battery, it's $524. A fully charged battery will last for 8 hours, and it's not currently eligible for Medicare reimbursement. I tried to figure out exactly why, and from what I understand is that Medicare stopped covering this product in July of 2021, basically saying due to the cost of the equipment, they needed further research before approving it. So, PureWick is approved for urinary incontinence in females. It is not approved for use with urinary retention. They'll basically place this small little cylinder device in the between the labia, and it helps pull the urine away from the body for patients who are incontinent at night. The canister can hold 1,800 milliliters of urine. And the box of external catheters is $195 per month. So that means once you buy your starter kit for $594, you would then need to spend $195 per month for your catheters if you're using it every night. I think it's important to know that these catheters are only supposed to be used for 8 hours at a time. So this is what the system looks like. You can see the canister there that provides suction, and then the small external catheter for the female. So we're going to talk a little bit more about the PureWick devices here in a moment, but let me quickly cover bladder scanner. So just back to the basics on this. Remember that if a female has a hysterectomy, you need to change the setting to the male setting. You can have inaccurate results for the following conditions if the patient has a lot of ascites, if they're overly obese, if they have a large or a small bowel obstruction, or a lot of abdominal adhesions. If the patients have any of these conditions, then I do recommend a PVR that's obtained via straight catheter in the clinic. All right, well, here are my references. And urology, you're in good hands. Thanks.
All right. Let's see. You have to quit sharing your screen.
Yeah. One moment here.
That's all right.
Very nicely done.
Thank you.
Yeah, great talk. For those folks in the audience, feel free to start putting in any of your questions. I know but I was writing a whole bunch of stuff down here.
Questions, comments, experience, or horror stories that you may have gone through yourself, feel free to share them in the Q&A.
Oh, I have one more thought on the PureWick device. I actually had a patient the other day who used the PureWick inpatient. She absolutely loved it. Was then transferred to a nursing home where she's going to be long-term, but apparently her nursing home will not allow any of their residents to use the PureWick catheters because they're having patients that were having urethral, or not urethral, but labial erosions. So my guess is that the patients were probably using it longer than the recommended 8 hours, but I'd be curious if anyone else has had issues with erosion of the labia.
So Neil, we were talking last week in the after hours. You said that you'd had several patients that you've treated with Dr. Kim. Can you comment a little bit about your experience?
Yeah, actually, I can say at least for in urology with Dr. Kim, we've had a lot of positive feedback from the PureWick system. The unfortunate thing is when it was covered by Medicare briefly, we did get a bunch of patients on this. And while it was covered, they loved it. The downside is it lost coverage shortly thereafter. And some patients continued to pay out of pocket for it and others just switched to different therapies. I did want to say one thing real quick about the labial erosion is that when I did see the PureWick used in an inpatient setting, it was often used for greater than 12 hours a day, and that is a bit of the issue. So I know that our understanding at the time was that it shouldn't be placed for more than 12 hours at a time, regardless of indication. And yeah, I think some nurses were just using it to avoid having to change linens as often, and that poses a problem.
Yeah, that would make a lot of sense that the target audience is somebody who's, with it enough to know that they need to change this thing and they're not just leaving it on for extended period of time.
Definitely.
So
Well,
now
not
patients,
not necessarily someone with it enough. I one of the administrators of a PureWick users group on Facebook. It's a small group of folks who either use PureWick or folks who take care of others who use PureWick. There are folks who use PureWick. They don't really have a lot of sensation, dexterity, so their caretakers are the ones who are changing them. So it doesn't have to be the person who actually uses it who changes these catheters.
sounds good. Sounds like you just need to make sure that somebody's in charge.
Yeah. And although it is not, so the major hurdle is that despite the satisfaction of the users and the caretakers who care for the folks who use PureWick, despite the satisfaction and the ease of use and the effectiveness, the major problem is financial toxicity. We worry about drug toxicity, but financial toxicity is the major problem. I've learned from the users in the Facebook group that some of them, although not approved and not recommended, some users and their caretakers have took these apart and washed them and reused them successfully numerous times. So this is the part that's expensive, the catheter. And what they do is they peel this off, the covering off, and then take this portion off, and they wash this and then rinse this part off. So they wash this, dry it. People have come up with various concoctions to wash it, and then they reuse this part numerous times. So just FYI. And when you reassemble, here's a little trick. You put it back in. So this hose right here, you do not want to have it sticking all the way to the tip of this thing here. You want to leave a little bit of space right here. So it's things that I learned from the users.
Very
Makes sense.
interesting.
Otherwise, it would block the suction.
Correct.
We see that with intermittent catheters also. Again, the cost, patients try to bring down the cost by reusing. And, I've seen anything from rinsing them out to soaking them in vinegar water to whatever they, would do. And some, I'm sure your users group had the same experience. Sometimes it works, they can extend the life of it and save the cost. My curiosity is, I think it's not obviously a cheap thing to buy, but diapers aren't cheap either. So, I think that it could be a good trade-off.
Neither is treating like a skin breakdown from incontinence either. So, it's probably cheaper than that.
Yeah, absolutely.
Yeah.
I do have a question here. It came in from Susie Swain. Any advice on how to get good measurements on condom catheters? And what do you suggest patients do for any skin breakdown caused by the condom? Andrea, you have any thoughts on that?
Sure. So I think you're referring to the measurement. So I'll just bring in the little piece of paper, they're disposable. So bring that into the room and fit the patient in person in the room for the correct size. It's got a little divot in it. So you can actually, use that piece of paper that's disposable and apply it to the patient's penis to determine the correct size. And then you can select that size there. And I always tell my patients, just do 8 hours with these catheters because I'm working in the outpatient setting. So a lot of patients just really love the male external catheters for special events. If they're going to a wedding, if they're going to a ball game, if they're going to be out and about for the day, they can stay dry during that time. If they do have skin breakdown, I tell them just stop using it for a while, allow the skin to recover, and then you can restart using it. I don't know of any special products that are going to help prevent skin breakdown, but it's just really something to be aware of and allow the time for that skin to heal and try to use the catheter for the smallest amount of period or the smallest amount of time as possible.
And there are a number of different types of condom catheters out there. Going back to, I can remember there was ones that had a strap that kind of wrapped around them to hold them in place. And sometimes patients would put that on too tightly so it wouldn't slip off, to ones that are self-adhering, which I think most of them are now. To one I've seen that looks like a flower petal that goes right over the head of the penis. And that's all it covers is the head of the penis. I never had much success. They always seem to fall off for me, but I think that part of our definitely one of our tricks is to teach patients or make sure that we instruct patients to that they check the skin and make sure they're not seeing any, injury or swelling or things like that, and not to continue using them, because patients, once they're dry, they want to stay dry, and they'll sometimes deal with things that they shouldn't.
Yeah, absolutely. I find that for patient selection, males with Parkinson's disease tend to really like this product, because in Parkinson's disease, they'll oftentimes have urge urinary incontinence. And so I have a lot of patients with that diagnosis who like those products.
All right. I see a comment here from April McGriff. Good morning. I've watched several episodes via Android. I just figured out how to ask questions. Great. Or send comments. Fantastic. I've learned a great deal about catheters and Zoom. See, so we're not only are we teaching you about urology, but we're teaching you about technology. And just a little heads up, one of my talks in the future is going to be on technology. I gave a talk at the SUNA conference recently about technology, and I'm going to share some of that on our Zoom group here. But yeah, thanks for the comment. Gwen Hooper comment, all good information on PureWick, Dr. Lynn. So yeah, I appreciate the heads up. I haven't kept up with the PureWick, so when they were talking about it, I'm like, the pure what? But it does look like it's always good to see other options out there. Now, I had a question or maybe a comment. So when you were talking about the supra-pubic catheter change, you'd mentioned that changing it like every 4 weeks, 4 to 6 weeks. And I bring the question to the panelists. I tend to go longer. I mean, the first one I would certainly change at that time, but usually I find a supra-pubic catheter 8-12 weeks seems to be more than sufficient to stretch it out to. Any comments?
Comment on that?
Yeah,
Yeah.
go ahead.
So, historically, we've just always said, let's change it every 4 to, or sometimes every 6 weeks. But in our practice, we usually say every 4 weeks. And, maybe we need to do a better job of looking at what are the actual manufacturer's recommendations and how often they need to be changed. I have some patients who just have a lot of issues with the supra-pubic catheters clogging off. So for those patients, we would recommend more frequent changes. But that's a good point. Maybe we are changing them a little earlier than necessary.
And normally a supra-pubic tube is going to be bigger than a Foley catheter, which is usually a 16, maybe 18. Yeah, John?
And recall our excellent talk by Todd Thompson on episode 10 of UroNurse. He said, I think it was him who said that the recommendation by one of the manufacturers is to change the catheter out every 12 weeks. And the reason we started doing 4 weeks is financial for a lot of the catheter manufacturers. And I think Medicare started paying for them. So that's the reason that the recommendation, and also part of it is dogma. We've always done it this way, so we continue to do it this way. But one of the manufacturer's recommendations is actually change the catheter every 12 weeks.
Yeah.
No, his recommendation, he was like the guru of clog catheters. And he recommended dissecting the catheter and things like that. And what I'll do is I'll hit the link to that, to his video in the comments in the Q&A section, so folks can look it up. But he said that you should consider starting to lengthen out the duration of each catheterization. Instead of 4 weeks or 6 weeks, changing it, try lengthening it out to maybe 7 weeks, 8 weeks, and reassess the catheter, reassess clogging if there's any, and then go from there.
Yeah,
this is a great conversation. I think that just brings up a larger issue in healthcare. Sometimes we just do things because we've always done it that way. But we should be questioning, is it the right thing to do for the patient? So I'm gonna take a look at the manufacturer recommendations this week and figure out if there's a better way we can do it for patients.
Yeah, we always talk about how we want to have evidence-based practice, but boy, it's hard to get away from dogma. It's and people just grasp onto this. I've always done it this way. It's got to be right. Well, why? We got to ask ourselves.
Status quo bias is pervasive in medicine.
Absolutely. I did have, I know a comment I was going to make. You were talking about in teaching patients intermittent catheter. I'm working on trying to get Marianne Wasner from Hollister to give a talk. She's been busy with her job going on the road, but they showed me this thing at the meeting of these, like, it looks almost like playing cards. Actually, it drops them off at my office for the staff to use. I don't know if they've used them yet, but they're all anatomical pictures that can be used for teaching self-cath. I think it's all these learning tools are great to have. Provide whatever you can to try to help patients visualize what they're doing.
And it's really amazing how some women do not really understand their anatomy, where the clitoris is located, where the urethra is located, where the vagina is located anatomically. Many women are not using a mirror looking down there. So teaching them self-catheterization in a mirror, I think, is imperative so they understand, even though pictorially they see it, but nothing like when you are looking at it from your perspective on a mirror, because you're the one who has to put the catheter in. The patient has to put the catheter in.
Yeah.
Yeah. I have a few comments on female catheterization. When I'm talking to females who don't have good health literacy on where their urethra is located, I'll usually tell them, you have 3 holes, and your urethra is the hole that's closest to the belly button. And that can kind of help them figure out where that's located. And I will also have females and males really demonstrate catheterization in the clinic before going home if they're learning for the first time, because I have seen, unfortunately, patients who learn in the clinic, they say, oh yeah, I can do this. I got it. They go home, they're not able to do it. And then they have to end up in the emergency room later that evening to help with catheter placement. And that's very expensive way to do things. So I would recommend, if possible, to have patients demonstrate how to do clean intermittent catheterization before sending them off.
Yeah, good point. One thing I've noticed too is sometimes you assume that all the catheters are the same length, like especially the female catheters. And there are companies that make a little bit longer female catheters. And I found especially with women that are obese, that sometimes they have trouble because it's just not enough to hold on to with the catheter that this is not a catheter, by the way, it's a pen with the catheter that they use. So I've gone to some of the companies that produce a little bit longer one, especially with the handle part, and found that they had great success. So, keep everything, available. But as you said, return demonstration is key, because you may be able to get the catheter in, but if they're not able to do it, it doesn't do them any good.
Yeah. And in our postmenopausal female patients, oftentimes they can have vaginal atrophy, which will really cause the vagina to become stenotic and sort of pull inwards. And sometimes you'll even see, if it's severe, the urethra will be pulled really into the introitus. So that, just keep that in mind, that the urethra may not be as visible or in the same location after menopause.
Yeah, real good point. Susie Swain said, when teaching CIC, it's super important to stay positive. Definitely.
Absolutely.
Yeah.
Just building the patient's confidence is really important for these patients. And, sometimes I just have to remind my patients, like, hey, children can learn how to do this. They do it every day. If they can do it, we can learn it. And that's often encouraging for patients.
Yeah, I think it's a good time to put our coach hat on and become the coach rather than the practitioner, and really try to coach them on how to do it.
I was going to mention the irrigation port versus the inflow port for a 3-way catheter. I know some nurses may work in the ER, and some guys can come into the ER with clot retention maybe after surgery. I have learned because whenever they call me, I ask, well, did you irrigate the catheter? So number one, irrigate doesn't mean that you simply instill fluid into the bladder. It means you're pushing fluid in gently and then sucking it out. The goal is to irrigate and to suck out clots and try to clear the clots that way and unclog the catheter. In addition, you want to make sure that you're using the correct port. There are 3 openings on a catheter: the balloon port, and then the big one in the middle, and then the smaller, slightly smaller one. This is the inflow port for a continuous bladder irrigation. This middle port, the big port, is the port that you want to use when you're irrigating the catheter, not this one. The middle one, the big one, is the one that you want to use. So that's been a misconception, if you will, that I've noticed when I asked the ER nurse specifically. So exactly, tell me, how were you irrigating it? And often they'll just say they're putting in fluid and not pulling out the fluid to remove clots.
Yeah, that's a good point.
Yeah.
And for the
question,
go ahead.
I have a question question from April McGriff. Are all catheter lengths standard? Are there longer lengths available? I think the male catheters are all standard, but I can tell you that the manufacturers for female catheters are coming in different sizes. The one that I was thinking of, I believe, is from Lofric, that produces a special female catheter that has this. They've just made it a longer handle on it, so it's just gives you more to grip. Get samples from your reps when they come to the office. Ask those questions to them.
So this is a female catheter in a very compact package. So when you're carrying it, you don't really know. It looks almost like I don't know, something that lipstick or something, lip gloss. You open it, and here's the catheter is already pre-lubricated. And this happens to be a silicone catheter. This is made by Hollister Infina Chic, INFYNA. Pre-lubricated. This is the longer length catheter that they have. They just improved this. It's already pre-lubricated, so you don't have to wet it. The handle portion is, I think, is big enough for most people to manage.
Mm-hmm.
And when you're done, just put it in here, close it, and you discard it. They did lengthen this.
Yeah, so good point. And this is the things that we learn here. Come to find out more about catheters, and you're going to find out plenty.
So just a quick thing, for what it's worth, I have had larger female patients that have had difficulty doing CIC with any of the female catheters we've had, and I've had 0 pushback from any suppliers on ordering male catheters for those female patients. So it's never been an issue if it comes down to it. Like they can always just use a male like 14 French. As far as I'm aware, I've again never run into any issues.
Yeah, that's a good point. So all options need to be utilized. Again, we're the experts. Always tell my staff, you're the expert. Don't just hand the patient a bunch of catheters and say, figure out which one you like best. We've got to figure out what's going to work out best for them. And I think, as Andrea said, return demonstration is key.
And catheter manufacturers are very willing to leave samples in your office to get the patients to try different types of catheters. And they have, they keep innovating. Like Vic said at the recent, I think it was a SUNA meeting that you were attending, there's one where there's a handle that sticks out of the catheter that for females, so that they don't have to reach all the way around. They can hold on to the handle to try to guide the catheter into the urethra. Speaking of urethras, vaginal atrophy and carbuncle, as Andrea said, treating the underlying problem is important. And that is the use, most commonly for most women, the use of topical estrogen. And it's a great disservice that we are doing to a lot of women who are not getting estrogen in their system. And topical estrogen is extremely safe. And ACOG, American College of Gynecology, has a statement on their website touting the safety of topical estrogen and how it can help a lot of women. And not just the vaginal atrophy and carbuncle, but also overactive bladder and recurrent urinary tract infections. That's something that most people don't realize, that the topical estrogen is not just for sexual activity, not just for atrophy, but it also improves bladder function. Less frequency, urgency, and possibly urge incontinence, and also decreasing the risk of recurrent urinary tract infections for women.
Yeah, good point. It could almost be a talk on its own, just safety. Because I think a lot of people are afraid to hear estrogens and they're worried about breast cancer, et cetera. And this is not seen in the topicals.
Absolutely. That's a great topic to talk about.
Um,
I have one more just comment in general on clean intermittent catheterization. As I said, I have a lot of patients with neurogenic bladders and spinal cord injury patients. Even for incomplete patients with incomplete quadriplegia, I have been able to get them on clean intermittent catheterization. They'll oftentimes have to work with an occupational therapist. We have one at our facility who is excellent at helping patients figure out how to do this successfully at home. Sometimes it takes months of practice and trying multiple different products. They even have assistive devices. I think we have some SUNA presentations out there that cover some of these assistive devices, but I just wanted to impress upon you, don't just give up if with clean intermittent catheterization. There's many options for patients with limited dexterity, not just spinal cord injuries, but even patients who maybe have neuropathy and those kinds of things.
Yeah, good point. I had a comment on the supra-pubic catheter. I've had a lot of experience with these. One of the things, the tricks that I do is I look at the catheter that's in there currently and either measure how much is hanging out, or sometimes I'll just grasp it at where it enters so that I have a kind of a comparison with the one I'm going to put in, so I know how far to go in. I think that's because you mentioned you don't want to be pushing these in too far. I've seen patients, have the catheter go right through their bladder into their urethra, and then you're blowing the balloon up in their urethra and they're not too happy about it. So I think that's a good way to look at the one that's in there. You know where it's at. You kind of have a general point of view of where to start.
That's a great suggestion. I've even seen the surgical markers that they use for skin. I've seen some practitioners use that to mark the actual catheter on the amount that needs to be inserted.
Yeah. All sorts of tips and tricks. And that's what we get, when you take an experienced group of practitioners, you'll find out what they've been doing. Most of the time I change a supra-pubic tube with a two-handed technique. I take the one out, I put the other one in and do it in one shot. And this way here, I keep everything pretty much the same. And not that I'm worried, a well-established supra-pubic tube's not going to close instantly. I mean, most of them, you have about hours before they start to close down, but it's just an easy way to change it. Quick, they don't get, a mess of urine dripping all over the place. It's really convenient.
Andrew's comment is really salient in that the first supra-pubic tube change after somebody puts in the supra-pubic tube, that tract may or may not have fully epithelialized. So that first exchange is important. You want to make sure, number one, you replace the catheter expeditiously. And number two, you want to make sure that it's in the right spot. Because if the tract has not formed completely, so if you divert the tract or put the catheter in the wrong space, that can be pretty devastating.
Yeah, absolutely. Andrew, any thoughts on hydrophilic versus non-hydrophilic catheters? Preference for one or the other?
I personally prefer patients to use the hydrophilic catheters, especially for males, because I find that as the males are inserting a non-hydrophilic catheter, they put the lubricant just on the tip of the catheter. So it's well lubricated as they're inserting. And then when they get down towards the end, you'll see the catheter actually catching. You'll see it, catching on the end of the urethra. And I just get concerned that they could maybe have some scar tissue near the end of the urethra later in life. So I do prefer that. I don't know the current research right now on hydrophilic catheters versus non-hydrophilic.
Yeah. Neil, any thoughts that you have on that?
Honestly, yeah, I'm seeing the same thing. Like men tend to open the pouch of the lubricant and kind of dip the tip and just squeeze it. And then you have this huge glob at the tip, which is fine as long as it distributes as they insert, but that's usually not the case. So I usually start them out on the hydrophilics just for convenience, because I'm worried that they could also be contaminating the catheter as they try to lubricate it its full length. Real quick, I had a question in regards to CIC and neobladders. Aside from performing this more often to help prevent mucus buildup, does anyone have any special tips for this?
I don't see that often in my practice, but what I've seen in the past is just using a larger catheter, an 18 or a 20 French, and sometimes irrigating that, because the neobladders are made with bowel, and bowel will continue to make mucus, even if it's not in the bowel anymore. So you sometimes have to irrigate that mucus out. I've seen some patients recommend to do irrigation every day with those. Some patients don't have to, but that's my experience with the neobladders.
Yeah, we had one patient that was continuously going to the ER for mucus obstruction of his well, I should say not. He just could not get the catheter drained because there was so much mucus. So he came in and we irrigated him, and I showed him how much was in his neobladder. And he's like, "Oh my gosh!"
Yeah.
Fun side story on neobladders. We had a patient that with a neobladder who was supposed to be performing CIC 3 times a day, but just stopped doing it because he was having overflow incontinence and felt like he was just urinating normally, and he was being worked up for renal failure. And so no one considered that his neobladder is actually reabsorbing all that the nitrate and creatinine and everything and throwing his numbers off. And so we're just like, well, how about you start CIC before you do anything, like get back on it and see how your numbers improve. And turns out they did. So just kind of a fun aside on neobladders.
Yeah,
Well, not
good
fun
point.
so much, but
No, but it is a good point. Yeah. I
Yeah,
do have a comment from Gwen Hooper. In my clinic, the surgeon always does the first supra-pubic catheter change to avoid the issues you mentioned, Dr. Lynn. I think that's not a bad idea. The guy who put the catheter in probably knows the best where the track is.
Or know if there are any difficulties encountered during the placement, which is unlikely. When it comes to neobladders and irrigation, obviously mucus is the major problem. And as we learned from Todd Thompson, episode 10 of UroNurse, for say you take an 18 French latex and an 18 French silicone catheter, the outer diameter is the same, but the inner diameter of a silicone catheter is actually is bigger. The lumen is bigger. It can carry more fluid through. So maybe changing it to a silicone catheter for that patient may help with getting rid of some of the mucus a little bit easier. And as Andrea said, irrigation to help bust up or loosen up some of the mucus to facilitate drainage may be helpful. When it comes to male catheters or female catheters, I believe in equality. I think both sexes should have lubricated hydrophilic catheters. The male catheters now come in different, as Andrew said, it's like going to the grocery store and trying to buy cereal. There's a whole bunch of different catheters.
Yeah.
They come pre-lubricated. Not only do they come pre-lubricated, so they come in different sizes. It's not just a big, long package. They now come in a small package like this, pre-lubricated and ready to use. Some also come with an introducer tip because the distal portion, the most distal part of the urethra, that's where most of the bacteria, a lot of the bacteria resides because it's closer to the skin. So there's a little thing that you can put into just the meatus and then introduce the catheter, and the catheter is covered with a thin sheath of plastic so the user doesn't ever have to touch the catheter itself. And then you introduce it into the bladder, drain the bladder, and then remove it just the same way, all contained within the plastic sheath. Nothing ever touches the urethra other than the little introducer tip, pre-lubricated. So there's no more under lubrication. Look for those choices, options for your patients.
I've had only one case where I think that I had a good reason for not using a hydrophilic catheter, and it was just patient's dexterity. His fingers just kept sliding on the catheter because they're more slippery than anything you could. And for him, it worked better using a by lubricating, half of it, where he could at least control it because he couldn't catheterize with the hydrophilic. So there is no one perfect solution for all problems. So I keep that one in mind. At this point, we're coming to the end of our hour. I would like to thank everybody for attending. It's been great to have you all here. My regulars that are coming all the time, new folks that are signing up, we love it. I'd like to thank all my panelists. Couldn't do this without you guys. It's great. Neil, welcome to joining the panel.
Well, thanks.
It's fun to have you have your comments. Andrea, it's a great presentation as always. Dr. Lynn's always, your comments are great to have too. And I like the references back to the previous shows because they're all out there and we hope that you'll utilize those whenever you want.
Vic, one
And
more
I will
thing.
make a, yeah, go ahead. I will make a
Yes.
little pitch that we do have the after party coming up after this show. So if you want more, just go over into our website and click on that big button that says after party.
And one last thing before, and I know we're talking about catheters. One way for males to maintain continence is to consider the use of a urethral penile clamp. So you're compressing the urethra and you don't have to constantly wear a catheter. That's another option that we didn't talk about. Anyway.
Yeah. Could be another talk. There's a lot of
yeah.
those out there. So
Cunningham.
great
versus
ideas,
Leisner.
right?
Yeah, Cunningham
All right, folks,
clamp, yeah.
have a great day. For those of you that are going out and enjoying this great Indian summer, enjoy it. And